My case is a patient named Balwant Singh. He is a 70-year-old gentleman and farmer by occupation and a resident of Barmet. He presented with the complaint of pain and awareness of lump in his right upper abdomen for past 12 months. So patient was apparently well 12 months back when he developed pain in his right upper abdomen, which was insidious in onset. I'm audible, sir?
Yeah,
Sir,
you're audible and please go on.
which was insidious in onset, intermittent, mild intensity, non-radiating, non-referring, dull aching, and requiring occasional oral analgesics. The pain was episodic and occurred 1 to 2 times per month, with each episode lasting for 5 to 10 days. Then the pain was not related to food intake. For the past 4 months, these pain episodes have become 4 to 5 per month, and the intensity is also increased to moderate with a similar character and requiring almost daily analgesics. There is no history of any acute severe pain. The pain is associated with awareness of lump in the right upper quadrant for the past 12 months. The lump was when initially noticed was of a size of a ball, but there is a rapid increase in size of the lump for past 4 months, and the lump has now become a size of a melon. There is no history of jaundice, fever with twist or pruritus. There is no history of nausea, vomiting, abdominal fullness, or early satiety. There is no history of hematemesis or black tarry stool. There is no history of abdominal distension, alternation of sleep pattern, or altered sensorium. There is no history of blood in stools, alteration of bowel habit, or colicky abdominal pain. There is history of household livestock in the form of sheep, cow, and goat. There is no history of steatorrhea or pain radiating to the back or any trauma. There is no history of any other swelling. There is no history of any painful micturition or hematuria or flank pain. There is history of loss of weight, which is undocumented, and appetite for the past 4 months. There is no history of shortness of breath, cough, hemoptysis, or backache. In the treatment history, patient has visited nearby hospitals for his pain for past 1 year, and he took some medication for pain relief. He underwent some radiological imaging uh, last month, and after that, he was referred to AIMS Jodhpur. In the past history, patient does not have any history of similar complaints in the past. No history of hypertension, diabetes, tuberculosis, asthma, acute or chronic liver disease, or any prior surgery. No history of any prior blood transfusion. No, there is no family history of similar illness or malignancy related death in the family. The patient is currently not on any regular medication or has any known drug allergies. The patient is vegetarian by diet and has normal sleep pattern, but for the past month, his sleep is some affected by pain. He has no history of alcohol intake, smoking, opioid use, or IV drug use. He is married and has 3 children, and he does not have any history of multiple sexual partners. So, to summarize, my patient is a 17-year-old gentleman who presented with complaint of painful progressive lump in his abdomen for past 4 months with rapid increase in size for 4 months with anorexia and weight loss.
Dr. Jain, can we go back to the first slide? Keeping this in mind, what is your differential diagnosis?
Sir, my first differential is a malignant is of malignant etiology of a lump arising from liver of primary origin, sir.
Okay. So one thing I wanted to tell you, you shouldn't say ball size and melon size because they're subjective.
Okay, sir.
You should better to tell that it is doubled in size or tripled in size. And it was initially about 10 to 15 centimeters across, or the size of his fist, the patient's fist, you should say, because
Okay,
that
sir.
gives us some objectivity in assessing how much is the lump. If you say
Okay, sir.
a melon changes from small size to very large one.
Yes,
So
sir.
you cannot reconcile that with the history.
Yes, sir.
Understand? And never compare with food as far as possible, because that is distasteful and it leaves a very, to a pun intended, very bad taste in the mouth. Okay. Start from history of present illness. So he was well 12 months back, and in the past 1 year, he has developed the problem. And 4 months, it is increased in intensity.
Yes,
So,
sir.
what are the other possibilities that can be there? A liver origin lump, meaning what kind of lump?
Sir, liver origin lump of malignant etiology, sir.
Yeah,
First,
malignant etiology puts into your differential diagnosis what conditions?
sir, primary etiology would be HCC, hepatocellular carcinoma.
Okay,
Second could be intrahepatic cholangiocarcinoma,
okay,
and third could be of a secondary origin, sir, a metastatic origin, sir.
okay. What else?
Uh, Sir, next it could be a carcinoma gallbladder, sir.
Yeah. So, in your area part of the country, carcinoma gallbladder should be your first impression. Whether there is no jaundice or jaundice, as tumor situated at the fundus and growing hexophytically will produce a lump of this kind
Yes, sir.
along with momentum and everything and will produce this. You should also keep in mind xanthogranuloma as a possibility, xanthogranulomatosis cholecystitis, because that can have grown in the past 1 year and now it is growing rapidly because of infection, because of which pain is increasing, or there is a enlargement because of that region. Then
Yes, sir.
the other thing is, what about benign conditions? Which benign conditions can produce this kind of a lump?
Sir, in the benign condition, it could be a hydrated cyst, sir.
Yeah.
Since the patient is having a household livestock as well in the sheep, sir.
Yeah. So that was positive. So that is a good diagnosis. What about the explanation for his 4 months rapid increase in size? If it is the hydrated.
Sir, if it is hydrated, the rapid 4 month size increase could be due to cyst rupture, sir, which,
Rupture into the preperitoneal cavity or rupture into biliary radicle?
sir, rupture into the uh, biliary tract.
So is there any history of jaundice or anything? No.
No, sir.
So how do you say it's burst into the biliary tract? There's no such evidence for you. What happens when bile enters the cyst in
So
hydrated?
the daughter cyst dies, sir, and the cyst size should actually decrease, sir.
No, on the contrary, what happens is the bile irritates the epithelium and daughter cysts form for the first time. If it was a unilocular cyst, it becomes multilocular. And then, if it is infected in addition, it may cause a variable destruction of the cyst, but doesn't mean that the cyst is dead and no treatment is required. What are the conditions where you can say hydrated cyst does not require any further treatment?
Sir, hydrated cyst which is small, uh, which is calcified, and is calcified cyst stage 5, sir, which does not have any daughter cyst or any loculations.
Yeah, okay. Please go on.
So should I go to
What
examination?
metastasis can produce these kind of lesions? Where only one lobe is involved.
Sir, I could not get you, sir. Can you repeat, sir?
You didn't mention any diffuse fullness in the abdomen. You said it is a lump, so it
Yes,
is
sir.
smaller than the liver. So, what are the malignant secondary conditions which can produce a single large solitary lesion?
Uh, Sir, arising from the liver, as I mentioned,
That's okay.
hepatocellular
Secondary, I'm talking about.
secondary, sir, it could be a uh, metastasis from uh, of G of primary malignancy of J origin, CA stomach, sir.
Why CA stomach? Is there anything in the history to suggest CA stomach?
No, sir.
Then why did you say CA stomach? This is how you'll get caught out. You need to have other history that you can defend yourself when you make a diagnosis. Are there bowel and bladder symptoms? There are no bowel and bladder symptoms. There is no history of upper GI problem. So it's more in favor of a carcinoma gallbladder with or without metastasis.
Yes, sir.
Okay, go on. Next page. Yeah, tell us the examination.
Sir, on examination, patient is alert, conscious, and oriented to time, place, and person, sitting comfortably on the bed. His pulse rate is 80 per minute. His blood pressure is 122 by 72 mm of mercury, and respiratory of 18 per minute. Body temperature is 98.1 degree Fahrenheit. He has thin built, a BMI of 18.9 kilogram per square meter, and ECOG 1 status. On general examination, there is pallor, but there is no express lymphadenopathy or pedal edema. There are no signs of chronic liver failure.
Okay, so how will you explain your hepatocellular carcinoma hypothesis? Because most hepatocellular carcinomas arise in cirrhosis.
Yes, sir.
And usually cirrhosis will be slightly advanced before you can get HCC. You mentioned that in the history, you did not mention whether he had jaundice in the past, or you never took that history. But
I,
you only said,
there is no history of
yeah,
jaundice, sir.
but you didn't ask it. It needs to be asked. You only said no history of similar complaints in the past, no history of hypertension, diabetes, TB, asthma, acute or chronic liver disease. You have to specify what are the symptoms you're looking for. When you say acute or chronic liver disease, it's a vague statement because anything
Okay.
could be vague. Anything could be acute. Anything acute can be a vague diagnosis. You have to ask history of jaundice, whether he has any history of decompensation or episodes of decompensation. You need to ask this. It becomes important because when you're planning a transplant on a patient, a
Okay.
melon-sized lump is definitely out of Milan's criteria.
Yes,
So,
sir.
and even UCSF criteria also will not cover HCC. So you're immediately making a diagnosis that he has chronic liver disease. He has a lump which is very large. He's outside Milan criteria, and therefore he's outside UCSF criteria. Therefore, he might not be amenable for transplantation.
Yes.
So your mind should be focused on the therapeutic aspects of your problem when you're
Yes.
taking the history. So each sentence should tell us something more. You asked for no history of hematemesis or black tarry stools. What did you expect? Where would you expect that?
Sir, I asked for the GI symptoms of any presence of GI symptom. Uh, like first, if it was a secondary, then primary arising from stomach, the patient could have hematemesis or black tarry stool. If also, if patient is having a chronic liver disease, he might have an episode of melena or upper GI bleed as a result
Okay.
of chronic liver disease. Also,
Okay.
that's why I've asked for history of any prior abdominal distension for looking for decomposition in the form of ascites or
That's right. Okay.
alteration of sleep pattern.
Yeah. So go on. What is the alteration of sleep pattern you see in cirrhosis?
Sir, in
Advanced
cirrhosis,
cirrhosis.
patients have nighttime insomnia and daytime somnolence.
There will be reversal of the sleep pattern.
Reversal. Yes, sir.
So did you ask whether he was confused or dysarthritic or he was using unknown terms or he was hallucinating or anything? Because that can happen with decompensation of cirrhosis. So did you ask for any history of encephalopathy other than the fact that his sleep pattern is normal?
Sir, I asked for any alteration of sleep pattern or any alteration of sensorium with the patient as well as the attendant, sir. If he was,
So there is no such history forthcoming.
yes, sir.
Yeah. Is it possible for getting a HCC in a patient who does not have background cirrhosis?
Yes, sir, it is possible.
What are they?
Sir, in the background of patient having an elderly age, the risk factors are for SCCR, one is age, sir. Another is any exposure to aflatoxins. Uh, Patient is a known case of hepatitis B virus or a history of hepatitis B virus or hepatitis C virus carrier can also have, sir.
Okay. And in India, you see a significant percentage of people without chronic liver disease developing HCC. So that's an important thing to remember. If I remember
Yes,
the figure correctly, it's as high as 10% of people.
yes, sir.
Yeah. So what else would you like to ask? What about signs of dissemination?
Sir,
Where will a
for,
HCC disseminate to?
sir, HCC will can disseminate to bones, sir. So I've asked the history of patient, history of any backache, sir, in the patient.
Okay, lymphadenopathy, paraortic lymphadenopathy. What else?
Also, the patient can have metastasis to lungs, sir. So I've asked for any history of shortness of breath, any cough or any hemoptysis.
Will you get hemoptysis in lung metastasis? Dr. Kapoor has said this numerous times that the only thing you can get is symptomatic breathlessness because of pleural effusion developing or because of a large volume of lung tissue getting involved. Hemoptysis is very rare, but it can be tuberculosis, which can present with a lump in the liver. Though a rare diagnosis, in India it's a common disease, so we do see such cases where it mimics a tumor, but it's actually tuberculosis of the liver.
Yes,
Yeah. Okay. So, what about the history of all the livestock? How is that relevant to your diagnosis?
sir. One of my differential was a hydrated cyst of liver, and
Yeah.
the sheep is an definitive host in life cycle of Echinococcus granulosus, which is the causative
Definitive or
organism.
intermediate?
Sheep is the definitive, sir.
Do you mean to say that the sexual part of the life cycle occurs in sheep or it occurs in dogs?
Occurs,
Only a cyst forms
yes,
in
sir.
sheep. The proglottids and all that are ingested and then it grows to a full adult worm in a dog. Sexual reproduction occurs, eggs are produced, cysticerci, and these cysticerci are released in the stools.
Yes,
And when somebody eats, when a human being eats contaminated food, then he develops a hydrated cyst over a variable period of time. So the definitive host is the one where the
sexual
life cycle of the animal occurs or the organism occurs. So in this case, a dog is a primary definitive host, sheep is a intermediate host, and man is a accidental
yes,
intermediate host.
excellent.
Yeah. So can you tell me a little bit about the life cycle of echinococcosis? How do you recognize what are the different kind of echinococcus infections that you know of?
Sir, first is liver hydrated cyst. Another could be a pulmonary hydrated cyst, sir.
No, no, no. In the
It could
liver itself, what are the different echinococcus granulosis, echinococcus
a
alveolaris?
little bit.
So all these conditions, how does alveolaris differ from echinococcus granulosis?
Granulosis, Echinococcus granulosis, the morphology is usually a single liver hydrated cyst. The Echinococcus alveolaris often presents as a multiple hydrated cyst in the liver, sir.
Is it multiple or it doesn't have a clear distinction line? While echinococcus granulosis, there is a single or a multiple cyst, but it is usually
Use,
unilocular and well differentiated wall is present in the form of a pericyst. In alveolaris, pericyst doesn't form and it behaves more like a tumor. There are more solid elements and it behaves more like a tumor. Okay? Yeah. Go on. So, how does being with a sheep or this thing affect him? He may have dogs to take care of the sheep and or cattle, or it might be that way, but it won't be directly like you have mentioned in this case.
yes,
Livestock is a danger for other infections, like if he drinks the milk, he can develop Mycobacterium bovis if he has got a cow. So these conditions become more likely. Yeah, please go on. Yeah,
Sir,
start.
in the abdominal examination, on inspection, his abdomen is covered with central and inverted umbilicus. In the There is a lump of 8 cross 5 centimeter visualized in the right hypochondriac region, which is extending to epigastric, umbilical, and right lumbar region, and is moving with respiration. There is no scar, sinus, fistula, or any dilated vein seen, no renal angle fullness, and bilateral hernial sites of in the palpation. There is no superficial tenderness over the abdomen. A hard, non-tender mass of 14 cross 10 centimeter is palpated from starting from below the right subcostal margin in the right hypochondriac region and extending to epigastric, umbilical, and right lumbar region. The surface is irregular with well-defined right, left, and lower border. The upper border is not palpable and is in continuation with the liver and costal margin. The mass is intra-abdominal and it is moving with respiration but does not have any intrinsic mobility and is non-pulsatile. Liver is palpable till 3 centimeter below costal margin on left side on deep inspiration. The surface is smooth with regular borders and soft consistency. The spleen is not palpable. No other lump is palpable. Bilateral hernia orifices are free. On percussion, the liver dullness starts at fifth intercostal space and is the lump is also dull on percussion. The whole liver span in mid-clavicular line is 17 centimeter and no bilateral flank dullness is present. On auscultation, normal bowel sounds are heard. On rectal examination, there is no normal anal tone, not no rectal deposits are felt, and fecal stain was there on gloved finger. Rest of the systemic examination is within normal limits.
Okay. So is that done?
Yes,
Yeah. Go back to your first slide of the examination. So you mentioned that inspection on 18 to 5 centimeters is visualized, which is a relatively small swelling.
yes,
Yeah. And you said that it is moving with the respiration.
yes.
So a lump of that size moving with the respiration, what are the possibilities?
Sir, first could be a mass arising from the liver, could be malignant or benign. Second, it could be a gallbladder mass, which is again moving with a respiration.
Mhm.
Third could be a third could be a lump from
Basically,
the
this is an upper abdominal mass. But I
yes,
fail to see how an 18 to 5 centimeter lesion can occupy three quadrants of the abdomen, right hypochondrium, epigastrium, and lumbar region. It has to be larger than that.
so on the inspection it was of this size and
And on
but
palpation, what did you mention
palpation
about palpation?
palpation the full extent was 14 cross 10 centimeters.
Okay.
So
What kind of a border was there on the lump? Was it a rounded border or a hard, irregular border?
it
Your
was a
written surface is irregular and well defined right, left, and lower borders. So,
yes
what is the consistency of the lump?
sir, it was a hard lump which is non-tender and the surface the borders were irregular and the right, left, and lower border was well defined, sir, but the upper extent was not palpable. It was in
Okay.
continuation with the subcostal margin.
Yeah. So, now with these possibilities, what are your possibilities now? They are similar to what you said before. But
Yes,
I would say that you should also consider cystic tumors of the liver and cystic tumors of the pancreas, because cystic tumors of the pancreas may give, especially if they're situated anywhere close to a larger organ which moves with the respiration, they may give a false impression of moving with the respiration. And it has been shown on CT that even pancreatic masses move up to 1 centimeter with the respiration based on CT measurements. They're not totally immobile. So a slight movement that might be appreciated on inspection or palpation should be negated. It should be a
yes,
significant movement, more than 2 to 3 centimeters movement with deep respiration.
okay, sir.
Yeah. What is the importance of intrinsic mobility?
Sir, if
Tumors
the
are intrinsically mobile.
if it could, sir, the if the mass could have been arising slow-growing tumor arising from stomach or duodenum could have some mobility. Also, a pedunculated mass arising from the liver could have some mobility. But the fact that the lump was not having any mobility on its own, it was moving only with respiration along. That's why it's
Was there
like
an anterior band of resonance on this swelling?
no, sir.
Yeah, if that was there, what would you think it would be?
It could be in a renal lump, sir.
Yeah. Was this lump crossing the midline?
No, sir, it was not crossing.
Yeah. So is a renal lump still possible? What are things against renal lump?
Sir, there was no history of any flank pain, any hematuria, or any urinary complaints. Also, the bilateral, the renal angle fullness was not there, and both on inspection and palpation, sir.
On percussion?
And on percussion, the surface was dull, sir.
So if it was dull, was it dull in the kidney angles as well? In the renal angles, what was the note? Did you check that?
That I've not checked.
Yeah, you need to do that because you might not see an obvious lump, but you
Okay,
can see tenderness in the renal angles. And if there is fullness in the renal angles, it puts it in favor of a kidney. Otherwise, it could be or could not be a kidney lump.
yes,
Yeah. So also not moving with the respiration, kidney again moves just 1 centimeter with deep inspiration. Uh, but your mass is moving with the respiration. So it's more likely to be either a stomach mass, liver mass, or a colonic mass. Can it be a hepatic flexure colonic mass?
yes, sir. It could be, but the patient does not have any history of any alteration of bowel habits or blood in stools, and
In a
size.
right-sided lesion, would you expect much change in bowel habits?
No, sir. We won't expect.
See, what is
Also,
the common presentation of a right-sided tumor?
the patient complains of generalized weakness, sir, as these tumors are often have slow bleeding, and patient sometimes complains of blood in stools or a melena, and most commonly complains with weakness, sir, generalized
He has
weakness.
anemia also. On the clinical examination, you said he is
There was
pale, if I remember.
yes, sir.
So if he is pale, can it not be a left-sided colonic mass? Sorry, right-sided colonic mass.
Yes, sir, it could be, but since there was no the lump of this size, sir, 14 cross 10 centimeter.
Does it move with respiration hepatic flexure?
Yes, sir, it moves.
Yeah, so you can't rule it out. A large mass in the colon can infiltrate a lobe of the liver and give
Yes,
that appearance, or you could have two lumps, a primary which is small and a secondary in the liver which are actually palpating and saying it's a tumor.
yes,
So you should necessarily not rule that out. So you should have that in your differential diagnosis. Another thing is cystic malignancies of the liver. What are the cystic malignancies of the liver?
sir. Cystic, sir. Sister, uh, biliary cystadenoma, sir.
Yeah, and biliary.
Biliary, IPM and B, sir.
Biliary cyst adenocarcinoma, not IPM.
Yes.
IPM is seen in the ducts, it's not seen in the liver.
Okay.
And it's mostly seen in the pancreas.
Yes.
Yeah, go on. Show your differential diagnosis. Now defend your differential diagnosis. Tell us the points in favor and against for each of your differential diagnosis.
Sir, points in favor of primary malignant SOL is that a patient is an elderly male with an history of a lump arising from the right upper abdomen in for past 12 months with a recent rapid increase for 4 months, which suggests a malignant and with loss of it and appetite, which suggests a malignant etiology. And since on symptomatology, there was no history of any uh, organ, any GI symptoms or GI symptoms suggesting that a patient could be having a primary malignant as well of liver. The points against sort of primary disease are: one, the patient is having pallor, so he could have a mass arising from the uh, colonic of right colonic origin, small mass, which could be giving this a secondary the lump which is palpable could be a secondary metastasis arising from the primary of colon cell.
Yeah, okay. Go on next slide. Tell us the investigations.
Sir,
What are the investigations you would like to do?
sir, I would like to order two sets of investigation for the patient. One would be blood investigation, including complete blood cell count, liver function test, kidney
Is that a
function.
priority? Wouldn't you like to know whether it's a disseminated lump or if it's not a disseminated lump, whether it's a malignant lump which has a chance of dissemination? Because if that is the case, would you even need to do all these investigations? You wouldn't need to do these investigations. So don't, as a you're an MCH student. So you should
Yes,
look at it from this point of view. You subject the patient to as little harm as possible and as little discomfort as possible. So I would say imaging should be your initial test. Then, based on imaging, you can order specific tests. And the basic imaging modality that you should use as a first screening tool is an ultrasound of the abdomen.
yes,
You understood my logic?
yes, sir.
Yeah. So let us have the investigations. You tell us in your order. Blood investigations first.
Sir, the blood investigation, the first complete blood cell count, hemoglobin for the patient was 8.1.
So anemic.
TLC is anemic. Total leukocyte count was 5,870 and platelet count was 3,65,000.
Yeah.
In the LFT and INR, the patient's bilirubin was 0.92 and direct was 0.37. OTPT and NALP were in normal limits. Protein albumin was 7.87 and 4.19, and INR was also 1.01.
Yeah. This rules out chronic liver disease. Understood.
Yes.
Next.
The KFT electrolytes, the urea was 45, creatinine was 1.32, and the sodium potassium was 133 and 4.5.
Yeah. So what do you have to say about the creatinine?
So, since the urea and creatinine are slightly elevated on the higher side, so patient could be having dehydration, and uh, I would like to
Does
give
creatinine
hydration to
rise
the
in
patient.
dehydration? What rises in dehydration? If there is a patient of acute dehydration,
Yes, sir.
what blood test will become abnormal?
The patient is in dehydration, sir. The urea will be elevated, and creatinine will be more towards only urea will elevate.
Mostly urea and blood urea nitrogen will increase.
Yes,
While if it's an acute renal injury, creatinine doesn't have time to rise. But if it's a more chronic liver injury, he's an elderly man.
yes.
Uh, is he a hypertensive? He's a normotensive.
N-
But if
Normotensive,
he,
sir.
yeah, if he's a hypertensive, that could be one cause for this. He could also have CKD. Why is CKD so important to you? Why did you do this test? It's
Sir,
turned out to be normal, fine, but why did you do this test? Nowhere in your clinical examination you mentioned the patient was dehydrated. Nowhere in the examination it is pointed out that he has renal disease. We only have a possibility that it could be a renal tumor, but that too very vague, just because it's situated in that location. So why did you do a blood urea creatinine and how does it affect your treatment? If
sir,
this was let us assume it's a primary malignant tumor of the liver
yes, sir.
and it's not this large. So what implications does renal function have in these patients?
Sir, in this patient, since this patient will be further subjected to a radiological after ultrasound, possibly a CCT scan or an
Yeah,
MRI, that
yeah,
could have implications, sir.
yeah.
For
So,
that,
so with a 1.32 creatinine, would you prefer to do an MRI or would you prefer to do a CT or not do both?
sir, I would re, hydrate the patient, sir. Give a fluid challenge to the patient. Give 1 liter IV fluid and repeat after adequate hydration. I would like to repeat the creatinine for the patients.
Dr. Jain, you did not even mention anything to suggest dehydration. There is no loss of skin turgor. There is no excessive wrinkling of the abdominal skin. Skin turgor is normal, which you have not examined. So, without knowing that, how do you just simply, you didn't mention the JBP, you didn't mention whether there was pedal edema. So, how will you justify giving 1 liter fluid to such a patient? If he's a normal patient, okay, he will tolerate it. But assume he has chronic renal failure. Wouldn't you cause fluid overload?
Uh, Sir, it could cause fluid overload if the patient was a known chronic kidney disease patient. But since in our usual practice, often if we without patients, sometimes we get without with dehydration without any obvious clinical features. Sir. So there could
So,
be
that would be
sometimes
a
the
mild dehydration.
mild dehydration. So
Okay.
in
So,
such
you have
patients,
given this fluid.
often
After how
yes,
many days will you repeat the test?
we usually repeat after 24 to 48 hours. Sir.
You expect it to come down so soon?
Sir,
You didn't mention anything about his urine output, how it was. Was it a normal urine output, reduced urine output, high colored urine?
the urine output was normal. Patient was staying around, passing around 1 liter of urine
So,
output daily, but it was not
why the
substantial.
diagnosis? Why the diagnosis based only on biochemistry that he has renal dysfunction? He has dehydration. What is your? I want to know how you are thinking it's dehydration. Giving him half a liter of fluid won't do him any harm.
Yes,
But the point is why? You need to know why. You need to be able to explain why. You are going to say my blood urea is slightly raised. The blood urea creatinine ratio is slightly raised. That's why I would think of doing a dehydration. That's the answer I expect from you. So you repeated the test. Did it come back to normal?
yes, sir, it was decreased to 1.21, sir, after. Uh,
So still abnormal, just borderline. 1.2, most centers 1.2 is considered as normal creatinine. Can you tell me something about creatinine and its value in assessing a patient?
so the value of creatinine is it indicates patient is having a kidney disease, a chronic kidney disease. Also, rise in uh, creatinine from baseline normal, sir, indicates uh, patient is having some acute renal failures.
No, what about, is it the pattern of creatinine measurement serially done where there is increase or decrease? Is that more important or is a single value more important?
The pattern of creatinine is more important.
What are the physiological factors that result in a lower creatinine? Suppose he is a 70-year-old man, what was his muscle mass like? Because creatinine
The
output is dependent on the muscle mass.
muscle mass.
Suppose he is a frail man, his creatinine will go up much more slowly than if he was a well built muscular individual because he's not producing enough creatinine. If he's frail and thin and elderly, his creatinine might appear normal, but in fact, it is very high for his physiology. So it's not absolute values that you should be concentrating on. You should be concentrating on patterns.
Yes,
Yeah, they go on.
sir. As a part of baseline investigation and suspicion of a liver mass, we have done viral markers also for this patient, which
Okay,
was the hepatitis B surface antigen was positive, and hepatitis C virus and HIV 1 to 1 negative. Sir.
okay. What about hepatitis B core antigen? What is
Sir,
the importance of hepatitis B core antigen? When would you do that?
Sir, hepatitis B core antigen will, if a patient is HPSAG positive, and the core antigen will indicate the patient is having active infection, sir.
Okay. So now that you have a HBsAg is positive, are you trying to tell me this is a cirrhotic liver? Because the liver had a sharp border, there was no rounding of the borders, there was enlargement of the liver which could go for this. But is it possible for a patient with hepatitis BAG be still non-cirrhotic or early cirrhotic child A and have normal function?
Yes, sir, it could be possible in hepatitis B carrier patient, which is a known risk factor for HCC, and also these patients can have a non-cirrhotic or a child cirrhotic liver, sir.
Okay. So what other tests would you like? Once this HbSAg is positive, what tests would you like to do to assess his status?
Sir, I would like to do hepatitis B core antigen, HPV DNA, sir, to know the disease burden, sir, and
What else? What
uh,
about
family, and also
EAG, E antibody? Don't you want to
HB.
do HBeAg? AB, I
Yes,
mean. Why? What is the importance of HBeAb?
HBe antibody indicates a remote uh, infection of the patient, and
No, it doesn't. It only says patient is not a supercarrier. The replication rate and the DNA load would be much higher in a patient who is HBeAb negative. If he is HBeAb positive, it would mean that he has a lower disease load and the body has posted some immune response to his HbSAg. Okay.
okay,
Please remember that hepatitis A, B, and C are part of the curriculum of surgical gastroenterology. So you have to consult medical textbooks and know everything about these diseases and be able to answer them.
yes,
Yeah, please go on.
sir. We have
No, the
done,
previous,
sir. Actually, these were done
previous,
after,
yeah. Tell us this.
sir. That in the tumor markers, actually, we have done this after the ultra imaging of the patient. But
Okay. Anyway, it doesn't
uh,
matter. Tell me now.
in this, the alpha fetoprotein was 594.5. The
Okay.
CA was 1.07, and CA 99.9 was 11.94.
Yeah. So what are the likelihoods?
Sir, since more AFP more than 200 indicates is a diagnostic of hepatocellular carcinoma, sir. So it
Is it
indicates
diagnostic?
presence.
How much is diagnostic?
So more than 200,
More than 400.
more than 200.
More than 400 is diagnostic. More than 200 is you have raised AFP. It has to be more than 400 for you to be able to call it a uh, positive marker.
Okay.
Hmm. Go on. Go on, next slide.
This was the ultrasound abdomen of the patient, sir, which
Yeah.
he bought from outside. In this, the liver was enlarged in size 17 centimeter with a large heterogeneous mass lesion of 15 cross 14 cross 11 centimeter in the right lobe of the liver, predominantly arising from segment 6. There was multiple hypoechoic area within the lesion, likely necrosis. The lesion was closely abutting and causing mass effect over upper pole of right kidney, main portal vein, and the overfinding suggesting of neoplastic mass lesion. Also, there were small hyperechoic lesions in the right lobe of liver of largest of 10 cross 15 mm in the segment 7 of liver, query nature, query satellite lesion. Uh, so,
Okay.
and the rest of the examination, ultrasound findings were within normal limits, and their the final impression was a neoplastic mass, likely HCC.
Yeah. Another advantage of getting an ultrasound is it tells you to concentrate your investigations on a particular area. So now that we have this HCC possibility definitely in the game, What implication does abnormal renal function have to you? Is it relevant in transplantation? Does it affect transplantation?
Yes, sir. It affects transplantation. The
How?
presence of a altered renal function in the background of CLD or NHCC, sir. It indicates a poor prognostic implication on outcome of liver transplant outcome in patients, sir.
That is one. Plus, what is the implication? Suppose you do a transplant. He is not very bad. You rehydrated him. His creatinine came to near normal. So it's less likely that he has chronic kidney injury. But let us assume it was a creatinine of 2 to 3. What implications does it have on doing a transplantation? When you do a transplant, what are the factors you will be taking care of? What would your immunosuppression be like? What would your intra-op management be like? What would you do differently or the same?
Sir, if we are planning
In your
transplant,
center, you have transplantation, Dr. Jain.
yes,
You
sir.
have
Yes,
you are
sir.
doing transplantations.
Yes, sir. Starting from this year, sir, we are
Okay,
doing transplants, sir, once in 2 months.
okay,
Sir, in the presence of background deranged renal function in liver transplant in the intraoperative period, I would like to not over avoid over fluid overloading in patient. In such patient, also the we will avoid giving any nephrotoxic drugs to the patient, and also the postoperative antibiotics and the antibiotics which are given to such patients, which like carbapenem, which are especially nephrotoxic, sir. So we will do according dose management, sir. Dose need to be calculated after calculating the creatinine clearance in such
very good,
patients.
very good.
Also, tacrolimus is given, sir. So it is also will also cause some nephrotoxicity. So that also needs to be kept in mind.
What about cyclosporin?
The cyclosporin is also a nephrotoxic drug, but
What
in
group
our
of drugs do what group of drugs do tacrolimus and cyclosporin belong to?
sir, they are tyrosine kinase inhibitors,
No, they are calcineurin inhibitors.
calcineurin.
Yeah. Tyrosine kinase, I don't think comes into the picture at all at this stage.
Got it wrong. Calcineurin. CN.
What are the mTOR immunosuppressive agents?
Sir, other immunosuppressive agents, sir. Uh, sir, apart from calcineurin inhibitor, there is mycophenolate mofetil, sir, and
Yeah. So, would you
steroids,
use
sir.
mycophenolate mofetil in such a patient?
Sir, we can use, sir, mycophenolate mofetil, but uh, they are usually not given in the initial period, sir. Uh, they are in the immediate post-transplant MMF, sir. It is not nephrotoxic. Uh, exact rules. Sir, MMF can is given. It is not nephrotoxic, but it has caused bone marrow suppression, and after it is used after induction of immunosuppression.
Rajendra sir, hello.
Hello.
Hello, Rajendra sir, am I audible?
Yeah, I muted myself once.
Yeah, sir. Sir, we are reaching up to time, sir. It's near about 10, sir. So we have to
Yeah,
wind up
finish.
within another 5 minutes, sir.
Yeah, sure. No
Please.
problem. So what about, so what would allow you to do a hepatic resection? What factors do you want to check?
Sir, for hepatic resection, sir, I would like to see if the patient, what is the size of the tumor, exact size of the tumor, extent of the tumor, sir, whether it is involving portal vein, any portal vein thrombosis is present or not. If there are
Okay.
a presence of any other lesions, sir, in the same, whether in the same lobe or in the other lobe, sir, and presence of extra hepatic disease, sir, on the
Okay.
background of presence of any background liver disease, sir,
Okay.
size of, to look for size of spleen as well, sir, presence of splenomegaly, in, uh,
Which is not
which
there
can
in this
indicate
case.
presence indicating any indirect markers for portal hypertension.
Okay. Would you like to do an upper GI endoscopy?
Yes, sir. Since this patient is a hepatitis B positive, so to check for esophageal varices, I would like to do an upper GI scopy
Suppose
planning.
you found esophageal varices.
Yes, sir.
Suppose esophageal varices were present.
Yes, sir.
What test would you like to do on the liver to let you know whether it's resectable or not?
Sir, I would like to do an fibrous elastography for the patient, sir, to check for the uh, fibroscan of the patient of the left lobe, sir, especially because the right lobe will is
Okay.
occupied by the
And if
tumor.
it
So
is
left,
raised above, how much will you do a liver biopsy?
sir, in our center, sir, less than 7 as per our machine, it is below 7, it is normal. 7 to 14 is intermediate, and more than 14 is definitely fibrotic. So to rule out between 7 to 14, sir, uh, for intermediate, I would like to do confirm with the
And
liver
liver
biopsy.
biopsy. What kind? Transjugular, or you would like to do a percutaneous true cut?
Sir, I would like to do a transjugular biopsy in this patient.
Why?
Sir,
You said his INR was normal.
yes, sir.
So if INR is
Sir,
normal, APGT is normal, why would you do a transjugular? Transjugular is required when there is coagulopathy because there is a risk of post-transplant bleed.
yes,
That's
sir.
why you would do a transjugular. But if the clotting factors are normal and he is generally asymptomatic and the signs of chronic liver disease are not very severe, then you could do a true cut biopsy.
Sir,
Would you do a Mangini liver biopsy?
uh, pardon, sir.
Would you do a Mangini needle biopsy? There are different ways of doing liver biopsy. You have Wim Silverman needle, you have true cut needle, you have manganese needle. So which needle would you use?
Sir, um,
You would use
which
a
part?
true cut or a Wim Silverman.
Okay, sir.
You don't use a manganese because manganese just gets cytology. It doesn't get much of core.
Okay, sir.
Okay. Yeah. So what are your options for this patient?
Sir, the this patient, sir, can I open the CT of the patient?
Yeah, please. Anand will just take 5 minutes extra.
Sir, in this patient, since the tumor was 16 cross 14 cross 12 centimeter and involving arising from segment 5, 6, and 4B of liver, and it was compressing the surrounding structures without any obvious invasion. Also, the portal vein was compressed, but there was no frank involvement, sir. So, and so, sir, that I would like to do an MRI for this patient. There was also presence of satellite lesions, sir, in the CT. So, I would like to get an MRI
In both
to
lobes or in only one lobe?
in the CT, sir. They were visualized in one lobe only in the right side. So, to
Okay.
better characterize them, I would like to do a MRI, CMRI for the patient to look for their presence in the same lobe. What
Okay.
is their number, and whether they were present in the other lobe as well, sir.
Okay. So tell me the report.
Uh, in the MRI, sir, they have written apart from this lesion, there was uh, multiple lesions, sir, in the segment 5, 6, 7, and 8 of largest, which was of 1.5 to 1.3 centimeter, and they were at least 5, sir.
Okay.
So
In
the
both lobes.
in the both lobes,
Yeah.
sir. So other
So
lobe,
then what happens to your management modality? What would you like to treat it as? With what will you treat this patient?
sir, since this patient is having disease burden on the right side only, and without any background cirrhosis and no frank portal vein involvement,
You said
I would
metastasis was there in both lobes.
no, sir, only right side, sir.
Only
5,
right
6,
side.
7, 8.
Okay.
So
Okay.
since if this patient further, I would like to rule out any presence of extrahepatic disease, since this patient is having a very large tumor burden.
Yeah.
So I would like to do a PET CT for this patient to rule out
Okay.
extrahepatic disease.
Was there anything positive in PET CT?
Sir, actually, this patient is currently under evaluation only, so PET CT is planned, sir. It's
Planned.
still
Okay.
not done.
Yeah. Suppose you want to do a resection, what would the logic be behind your mind? First, he is a non-cirrhotic, but he is HbSAg positive.
Yes, sir.
So on biopsy, you should also look for chronic active hepatitis, chronic persistent hepatitis, because these have an implication on post-operative liver function. And
Yes,
what? Excuse me.
sir. Sir, uh, your voice got broken. Sir. Can you repeat, sir?
Yeah. Go on.
Sir, this patient, in the after ruling out presence of extrahepatic disease, sir, I would like to uh, do the CT volumetry of the left side of the lobe, sir. If first, uh, if we are planning any resectional procedure for the patient, I would like to know the remnant
Okay.
liver, sir.
How much should remnant volume be in a HbSAg positive but non-cirrhotic patient?
Sir, at least 40% can be safely, 40% at least should be there, sir, in a cirrhotic patient, child is cirrhotic, future remnant.
Okay. So would you prefer resection or would you prefer TACE?
Sir, I
When it's
would prefer
multiple
taste.
lesions,
I would
when
prefer
there are
taste.
multiple lesions, would you prefer TACE or you would prefer resection?
I would prefer taste for this patient, sir.
Yeah, I would do a TACE as well. I don't think I would subject him to resection because it's already showing intrahepatic dissemination and it is in all the four segments of the right lobe. It's not just restricted to the portal division of that lobe, and it's a
Yes, sir.
large mass. So I would prefer TACE. Only risk is it's at the surface. There's a risk of rupture because of TACE. So you have to be careful while embolizing, and you should keep your mind open whether you could have a HCC rupture. That is the only thing of importance. So, what is TACE and how is it done? Or would you prefer to do SIRT?
Sir, in our center we have facility for taste only. So
No, you can
in
always
case,
refer to a higher center if you don't have particular features. Except for cost, SIRT would be preferable because less chance of tumor rupture.
tumor,
And especially a surface tumor, you wouldn't like to give radiation because radiation of the surrounding tissue will
surface
also
surrounding,
occur. That is, the colon and the stomach would get irradiated significantly if it was a surface tumor. So those are the two reasons why we would be a little bit reluctant about TACE or SIRT. What about sorafenib? What is the indication for sorafenib?
sir. In, in the sharp trial, sir, it has shown to uh, show survival advantage in patients which are reserved with adequate performance status and liver and childish cirrhosis, as per BCLC classification. So sorafenib is advised, but sir, the recent trials have shown advantages of this immunotherapy, sir, in the form of bevacizumab and atalizumab, sir. So if the cost is not an issue, I will consider this for the patients.
Yeah. And if you are coming from a poor part of the neighborhood and the volume is sufficient, 40 to 50%, because it's hepatitis B and there is no activity in the liver, then I would do a resection. If there's activity in the liver in the form of chronic active hepatitis, I would be a bit reluctant because the chance of post-operative hepatic failure is more. Another investigation I would do is a portal pressure measurement transjugular. You would do a portal pressure measurement if there were varices. And if the portal pressure was high, you wouldn't do a resection. That's the things I wanted to bring out. So now
Sir,
we are about time. Yeah, go
sir,
on.
can I ask one question, sir?
Please.
Actually, sir, when you asked for a liver biopsy, the I said transjugular because I thought we will do that pressure management also. If it is more than 10, then that's why I was thinking of transjugular.
Yeah, but you should understand that when there is tumor in the liver, it's very difficult. When there are multiple metastases, it's very difficult to quantify the portal hypertension.
Okay, sir.
But I accept your logic. It's possible to do both tests together, but not with the same needle.
Okay,
You have to remove the needle and through the sheath you have to put in a occlusion catheter and then measure the pressure. And you should
okay,
measure the pressure in the remnant liver, not in the right lobe.
okay.
Rajendra sir.
Yeah.
So I think it's already 5 minutes past to 10, sir. So we
Yeah,
have to
I
close.
think we close the discussion. Very
Yeah.
nice discussion, Dr. Jain. Very well
Okay.
discussed.
Okay.
Thank you very much, Rajendra sir, for moderating the session, and thank you, Vishnu, for
Thank you.
Vishu for presenting in such a nice way. Thank you, everyone. So we are closing this session. Thank you.
Thank you.
Thank you.